Well, I'd like to welcome you all here today. This is our wellness webinar about non-invasive testing. I'm Wayne Eskridge, and while we wait for a few more people to join, I wanted to make a comment. I got my second Pfizer vaccine on Monday, and I was really pleased that yesterday I had malaise and a headache, and I wasn't feeling well, and that pleased me because that's a sign that my immune system was taking this seriously. And one of the things that, as a cirrhosis patient, that I've worried about is whether my compromised immune system was going to be receptive or be active against the vaccine. And I'm actually part of a Johns Hopkins study that is measuring the vaccine, the antibody response of people with cirrhosis. So I'm happy to report that I didn't really feel well yesterday, but I feel pretty good this morning. So one of the things that I want to pass along, we're in a position where we get to talk to the very best people in this field. We reach out to thousands of liver patients. We participate in planning societies. We're part of the people that comment to FDA. We're engaged in this business of getting drugs for liver disease. So I keep getting questions from people that don't think they're going to take the vaccine. And I really want to encourage anybody out here that's listening that they need to get the vaccine. There is no indication from the liver community that we should not get it. We believe that you're in more danger of dying from a fall than you are from having any problem with this vaccine. So if you're on the fence about getting it, please, 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 please do that. So with that behind us, let's go to the next slide.
Go ahead, Andy.
Well, we can go past that one. That's just me. One of the things that we do here is we may talk about things that are not yet part of FDA labeling or part of standard practice. We talk about cutting edge things a lot. We like you to know what's going on. So don't take this as medical advice. There's no medical, excuse me, there's no medical relationship or information here. This is just us passing along, our best information at this time, and we try to provide information about where the field is going. So I think that kind of thing's important, but we don't want you to overreact to it. Next slide. Our moderator today is Dr. Neeraj Mistry. He happens to be also the Chief Medical Officer of the Fatty Liver Foundation, and he's a professor at the Department of International Health at Georgetown, and he'll be guiding our discussions today, but I'll turn this over to him right now for a couple of thoughts. Next slide. These are our disclosures. We get support from across the industry and a lot of personal people, a lot of different types of organizations support this effort. Next slide. Neeraj, I'd like you to take over here for a minute. But you're on mute. Oh, well.
Okay, there we go. Can you hear me now?
Yeah.
Okay, excellent. Thank you so much. Sorry about that technical glitch with the mute button. So everyone knows Wayne. He's been our fearless leader, and he's been the stalwart representing the voice of the patient community. And it's through his lived experience over the years that he brings this credibility to the cause, and this in the absence of any effective therapeutics. And so the mainstay of his intervention has been lifestyle interventions. And a key to that has been Rosemary Wikowski, who has been his faithful carer over all of these years, effecting the behavior change and lifestyle modification to sort of reverse a lot of his liver disease. We also have another very special guest, Dr. Mona Munteanu, who is a wonderful combination of a research scientist together with a clinician. And marrying the two is really, really important in understanding what sort of technologies are going to be effective to change the field, as well as what the feasibility of implementing these technologies are. And Mona is the Chief Scientific Officer at Fibronostics. Next slide, please. Okay, so Wayne, over to you. Do you want to tell us about your story? And then we'll kick off with a few questions before opening to the audience.
Thank you. Very briefly, I was diagnosed with cirrhosis in 2015 by FibroScan, and I had a score of 21.5. And many of you know what that is, but a score above 12 at that time was considered to be cirrhosis. And since that time, I have been able to reduce that to what today is a 9.6. So over a period of 18 months, I was able to go from a very, very scary cirrhosis stage to a high stage 3, which is much more manageable. And I'm very, very stable in my with my liver at this point. You know, I'm certainly not in a safe place. I mean, I am a NASH patient with a compromised liver that's, you know, pretty badly beat up, but I've got the bugger in a stable place and it's meeting my needs. And so I'm really doing quite well. Next slide. Most of you don't get to look at your biopsy slides, I don't think. So I think it's interesting to share this. The one on the left is the biopsy when I was diagnosed, and that dark blue is the fibrosis. I mean, that's a classic fibrotic biopsy. The one on the right, which you can see that by that time, my liver stiffness had gone from 21 to 14. And what you can tell if you look a little bit closely is that the fibrosis is not as dense. It has got a feathery look to it. And that really is just visual evidence that scar tissue is softening and it's degrading a bit. And that's the reason why that stiffness score went down. And that's evidence that I was succeeding in regressing my particular disease. Next slide. So what I want to talk about today really is Fib4. Since we started the foundation, we have been advocating that people learn their Fib4 because this is something that you can do, that you don't need a doctor to do it first. You get these blood tests every year. And the FIB4 is a very simple calculation. You can find it on the internet, or you can find it on our website. And it uses the age, your AST, ALT, and platelet count. And it calculates a value which has been shown to give two signals. It gives you a low cutoff, which means below that value, you're quite safe. You don't have any particular risk of fibrosis. And it gives a high value, which says, you've got cirrhosis, you need to have that confirmed, and you need to be serious about this. And so you can see mine here, which was, which basically went from when I was first incidentally discovered to have liver problems in 2010, late 2010, December, really. And in that period, during that time, I should have been diagnosed in 2010, but I went through 4 years of very difficult conversations with my physicians because I had this picture that my surgeon had taken when he took my gallbladder out, and it was an ugly liver. And I kept showing this to my doctors and saying, well, what does this mean? How can I not be sick if I've got a liver that looks like that, you know? And during that time, my FIB4 was in that intermediate zone. And I finally got myself transferred to a transplant clinic, and it was just serendipity, really. But the very days that I crossed over up to the hazardous, above the high cutoff on the FIB4 was the month that I got diagnosed as having serious cirrhosis. So there was a signal there, and that made me wonder. And I went back into my old records, and I found you have these decadal medical reviews. I went back to when I was 50, and I was having a colonoscopy, and I was having all this. You're getting to be an old guy, so we better take a look at your studies. And at that time, when I was 50, I had just hit the low cutoff. So at that time, I should have, if that was to happen today, the appropriate thing for my doctor to do would be to seriously counsel me about where my risk was, because I was entering that intermediate area where the damage was likely to occur to my liver if I was subject to getting NASH. And at that time, we really didn't know that. We didn't understand those things, but we do today. And some of the things that we've learned in our various studies, the foundation did the SUN study, and we found that the people coming to us were in their 40s and 50s, and were having a significant amount of disease. And the FIB4 is such a simple thing. It really should be something that everybody does for themselves. So if you don't know your FIB4, or you haven't been really diagnosed as cirrhotic, or you know somebody that ought to think about these things, so I pass that along. You can find it on our website or out on the internet. So next slide. So that's just a bit of personal history. And as the science has developed, the research has shown that the FIB4 makes a pretty good pre-screener. We think of it that way. It's not diagnostic. It does not tell you whether or not your liver is in danger, really, but it gives you a checkpoint along the way that says you're okay, or you ought to be looking at this seriously or thinking about it, and maybe you need some education, and maybe you ought to be more serious about your lifestyle. And as it gets higher over time, that's something that you should pay real attention to. I mean, I went for 18 years. It took me 18 years to go from when I first hit the lower boundary to when I hit the top. And that's the nature of this disease. It's a decades-long process. And so I had ample opportunity to intercept that. I didn't have to become a cirrhotic. If I had known those things from that simple little blood test, I might have been able to not have to go through any of this crap, and you guys wouldn't be talking to me now. So the research that's going on right now is, okay, so what do you do after FIB4? And some interesting studies out of Europe recently was combining FIB4 with a test called ELF, which is another blood test. It uses some fancy molecules, and it only has 3. But if you take the FIB4 and you combine it with the ELF, you get a much better ability to define the level of risk that a person has. And so that's the way that the field is going, is we're going to be doing a screening process that goes through 2 or 3 steps before we get into the places where you're going to be referred to the fancy doctors with the fancy equipment. So next slide. Just to give you a sense of what that did, this is how doctors present this stuff at studies. But if you look on the right, the blue bars show the number of cirrhosis patients that were identified by this process that would have been missed in it with the simpler standard of care, with what we do today. So out there on the end, 14 people were identified as having cirrhosis, which is terribly dangerous. That and in standard care, only 6 of those would have been identified. So that's really important to understand. So next slide. My personal follow-up to FIB4 is a product that's done by Fibronostics, which is called LiverFast. And I wanted to share that with you because this is the nature of how we're moving with the non-invasive testing. What we want with non-invasive tests is a blood test that can guide us to next steps. Now, blood tests by themselves are not going to be considered diagnostic anytime soon. We may reach a place where FDA and some of the agencies might accept a blood test, that way. But right now we don't have it. So it's another step along the way before you have to go to the MRI machines and, the big fancy things, and before you start taking biopsies. So what this does, and I really like this because for me, what I want to know about my body is what's happening to my cirrhosis, my fibrosis, what's happening to my inflammation, which is what causes scarring, and whether or not I am rebuilding the fat in my liver. And this tool basically gives me what I know to be true, which is that I have an F3 liver. The A0 there is the inflammation, and it's really very low. And I have to credit my wife with that, because that's diet. That's the things you eat. That's lifestyle that drives that down. And the S0 over there is steatosis. That's the fat content of your liver. And my liver is almost fat-free. So I'm really, really happy with that. And my strategy is that I will periodically do this to see if I continue to manage my liver well. So next slide. I think I'm supposed to turn this back to Neeraj right now.
Thank you, Wayne. And I think, you know, the story that you just told us encapsulates all the different points in which we think about testing. And, you know, broadly speaking, there's the screening test that you talked about. And that's just the really simple, low-cost test that's going to identify risk. It's not going to tell us the extent of disease. So after the screening test, then we get to the diagnostic test, which tells us the severity or the extent of disease. And that test is a static test. It's at a particular point in time. And then it's interesting where we get to a monitoring test that should be compared because it tells us about changes that occur. And like you talked about, this is a long run disease where you see changes over a long period of time. So the more fine-tuned that diagnostic test is, the shorter the time period we can pick up changes in terms of progression of disease or reversal or halting of disease progression. So I think that's an interesting way to look at it as sort of screening, diagnostic, and then monitoring with testing. And with that said, you know, we were talking about this a few weeks ago, and I mentioned that you know, the liver biopsy, which was for a long time considered the gold standard in diagnosing liver disease, and still is in many research centers, was so 10 years ago. We were using this 10 years ago, and it was the mainstream. 5 years ago was the scans that had developed, the actual visualization through using FibroScan devices. And now it's about these blood tests, these non-invasive tests that we're talking about today. So my first question to Dr. Mona is, and as someone who's working in a company that's using these blood tests, these non-invasive tests with biomarkers, how is that evolution in thinking from actual visualization of tissue to scan visualization of the liver to now using these proxy markers? What was that sort of jump in technological and mindset thinking in order for us to get to this point?
Thank you so much, Neeraj, for your introduction, very warm introduction. Thank you so much, Wayne, for sharing with us and with the audience your experience and your trip through the disease, and for inviting me also to share my experience as a physician, as a clinician, and as a researcher through the struggling with getting better diagnostics for the patients. And also for us, because it's not very easy to take a liver biopsy in a patient. We have to combine them, and it's a procedure you know very well that it's absolutely not easily accepted by patients. So I had the chance to work in the last almost 20 years in the non-invasive testing of the liver field. And I personally had experience, and I studied and researched and developed a lot, participated in the development of blood serum biomarkers, and also in the elastography, transient elastography and two-dimensional elastography methods for the patient, and not only validating these methods against our clinical evidence, but also for validating the reliability criteria, how to interpret these methods. And this is a very important point, because sometimes even the physicians are getting completely lost with interpreting a result, because there are so many factors that could influence a result. So I have this vision, and also some the vision of patients' experience, because I worked for more than 15 years in a department, diagnostic, non-invasive diagnostic department in a big hospital in France. And so I can answer to your question, Neeraj. it was at the beginning, it was difficult to make something that it's not could not be visualized, that is not physical, like a physical measurement, like abdominal ultrasound, to be accepted as a replacement of the gold standard, which is liver biopsy. But this way to develop it was simple, because physicians discovered that some biomarkers could be correlated and independently correlated and predicting each one a condition like liver fibrosis or liver steatosis or inflammation in the liver. And we discovered also then that when we put together all these biomarkers, or the most significant of them, we are improving the diagnostic and the staging of this, and the clinical staging of this condition. And I think non-invasive blood biomarkers are based on this principle, that when you combine biomarkers, you obtain a more reliable result, more correlated with the condition that you are looking for. And of course, looking to the benefits and the risk, finally, non-invasive testing, it's quite well accepted, despite the fact that it is not what is called by the key opinion leaders the gold standard. But we know very well that the gold standard, the liver biopsy, has a lot of drawbacks. It's a procedure with high mortality and morbidity, and also it's a procedure, of course, that is not accepted and costly, and it's absolutely unadapted to the high number of persons having the risk to develop a chronic liver disease like non-alcoholic fatty liver disease or developing fibrosis, and it's not adapted for monitoring. So finally, these non-invasive methods are more adapted to the real life. And the same for the physical measurements that exist today, like transient elastography with FibroScan or other types of elastography. So this was the journey.
Yeah, no, that's excellent. And so I think we get a high degree of correlation with these biomarkers, or the combination of it, etc. And so a simple question really, but I think at the crux of the matter has come in, which is, well, how accurate are these non-invasive tests? How does that accuracy compare to the scans? And can we actually enhance that, not just by the combination of biomarkers, but the combination of non-invasive tests together with screening scans, for example?
Mm-hmm. Liver biopsy is considered the gold standard because it's a sample of the liver. Even if this sample is very little, it's like something like 1 in 50,000. You know, it's a very, very small sample and has variability, but this is the gold standard. And all these biomarkers, elastography or non-invasive blood tests like LiverFast or FIB4 were constructed and validated against the standard of care, which is liver biopsy. And the problem is, when you compare liver biopsy to a better diagnosis of fibrosis, like the whole liver coming from patients having liver transplantation or hepatectomy. This means to cut one part of the liver because of a nodule, for example. Pathologists observe that liver biopsy has also limitations related to the sample size. So if the sample size is too small, or if the fragmentation of the sample is too high, this could be a limitation leading to false positive and false negative results of the liver biopsy. So even if the liver biopsy is a picture, this picture could be false. Okay, or if the liver biopsy, sometimes it's we get the liver biopsy too close to the capsule of the liver. Also, the score, for example, of fibrosis could be overestimated, or if there is massive steatosis, the liver fibrosis could be underestimated. So liver biopsy is not a perfect marker. And this is why non-invasive biomarkers, they are constructed against liver biopsy. So they could have also some limitations. What is important when using non-invasive biomarkers is to know how to interpret them according to the what is called reliability criteria. This is called applicability or reliability criteria, and to eliminate or to interpret them according to the presence or absence of these criteria. For example, I can give the example of FibroScan. We know very well that patients having high degrees of inflammation, they will have higher scores of liver stiffness measurement, but this does not mean that they have higher fibrosis score. So a physician should know how to interpret this result of liver stiffness measurement in the context of the patient, looking to the inflammation, looking to the BMI of the patient, to the body mass index. If the body mass index is high, the accuracy of all physical measurement, ultrasound-based measurements are biased. So there are a lot of factors, like being fasting. This is required for all type of non-invasive testing, blood biomarkers or FibroScan. So if these factors are not respected, or if there is another disease that is interfering or another condition that is interfering with the result could be biased. So first, a non-invasive method should be interpreted in the context of the patient and of the clinical context of the patient. And of course, the accuracy of a non-invasive method, could not be higher than 0.19 on 1. 1 is the maximum, it's a perfect gold standard. But even the biopsy, it's not at 1. This is why we are saying that there is no marker that could, be higher, have a higher performance accuracy than 0.19.
So that's really interesting, because the more biomarkers we add in, potentially the more accurate the results we could get. But yet there is also a vulnerability that each biomarker may be influenced by some other factor which could skew the results. So looking at the patient in context is important. And this relates to another question that came in, is do we know if the liver fast results may be impacted by the COVID-19 disease or the COVID-19 vaccine? In that, are there any biomarkers that could be influenced by the presence of COVID or even the COVID vaccine?
Yes. Yes, this is a very good question. Thank you. So the biomarkers, it is not mandatory that more you put biomarkers, better will be. So it depends on what biomarkers are you, because you need to have a good combination. You need to have early biomarkers combined with late biomarkers that are able to diagnose the disease from early stage to late stage, as it is the case for liver fast. And liver fast, it's a combination that for the fibrosis score has some liver specific proteins, but it's not including liver enzymes like ALT and AST, SGOT or SGPT. And this is an advantage because it is not biased by inflammation and activity. And the COVID disease in patients having more severe evolution of COVID, they could have an increase in ALT and AST. And this is why liver fast is not biased by this indication. And of course, it is not biased by the vaccination. Vaccination, it is not influencing the biomarkers. Some patients could have, as Wayne described, influenza-like symptoms after the vaccination, but this is completely transitory. But in general, biomarkers should not be done when a patient is having conditions like acute conditions, like acute urinary infection or dental abscess or acute pulmonary infection. These biomarkers should be postponed for a moment at several days or weeks after this acute infection.
So it feels like there's a lot of promise on the horizon, and we're not there yet on what is definitive. I think, you know, the way we put the various diagnostic interventions together, whether we sequence it in a particular way, etc., that testing protocol is what's going to be really, really important to ensure the greatest sensitivity and specificity. Wayne, from a patient advocacy point of view, and you field questions from people who have a suspicion they may have liver disease, or were told something, or their cousin or uncle has something and they worried about themselves. What is the pathway that you are suggesting? And I'm not saying recommending, because, you know, the evidence is not absolutely clear, but what is the pathway that people should go down at this point?
Well, the problem that we face is the huge range of this disease. It's not something like a stroke that has an immediate beginning and process, or a heart attack that has an event, really. So we deal with people that come to the disease from the entire range of possible dysfunction, and the challenge that we have is that it's the tendency of doctors, or I guess it's a tendency of people, to try to simplify that. And so people are told, well, you have fatty liver, or you have NAFLD, but it's not a big deal. Go lose some weight and you'll be fine. People are told that all the way up until they're told that they now have cirrhosis. And, you know, that journey really is something that just confounds people, because they look back at their history of their medical record, or things that they've been told over the years, and they don't get why they, you know, like I have that same feeling, you know. I mean, at this point, I know I shouldn't really be blaming my doctor, but today we have young people. I have people coming all the time in their 30s that are saying, I've been told I have NAFLD. I'm scared to death. You know, I went out and looked at that on Google, and I'm afraid I'm dying. You know, well, what do I tell my children? You know, I have a 9-year-old. What do I tell my children? So the kind of information that people are getting is so lacking in granularity, and so disrespectful of just where people are in that process, that we create a huge amount of distress in people that are going through that. So we need ways to clarify that. And that's where I think that non-invasive blood tests can make a difference, because the Fib4 quite accurately can tell you, you know, if you don't have the serious kind of liver disease, which is NASH, that's when it starts to get scarring, and you're below that. I mean, you have a weight problem, or you have some kind of autoimmune thing otherwise, but you don't have a liver that's cooking itself to death. And when you go above that, then you need to start thinking about those kinds of processes, the things that really affect the liver chemistry, because at that point you're causing damage. And it's important to know that it's going to take at least a decade for that to become serious. So you don't have to be so frightened of it. What you need to do is to deal with it in a rational way over time. And still, we need to know, as people are approaching that upper levels in the Fib4, they need to be counseled in a more serious way. They need to be shaken up and grabbed by the lapels and say, look, you know what's coming if you don't get your act together.
Absolutely.
So we need to have the ability to think about the information we're giving to patients at these various stages. And I think that the non-invasive tests can do that. And for example, if I were, say, in the mid-range of the Fib4 today, I would want to do something like the liver fast, because I would want to know, okay, is my problem the inflammation? Is it the fat? What exactly is it that I'm trying to deal with? Because the diets and exercise and things that you do are what controls those things. So in that process, I would learn more about what I needed to do to not progress to a stage 4 cirrhosis. And I think that's the role that these things can play in society, is to keep us from hitting that F4, which is so terribly dangerous for people.
So I think you raise an important point, and Wayne, our constituency of patients for the Fatty Liver Foundation who follow your blog and go onto your Facebook page and listen to these webinars, they've been sensitized. They have been following this movement for some time. Our worry is sort of the walking wounded kind of thing, people whose livers are starting to be infiltrated upon, and they don't know this. And this is where the role of testing is so important. So I'm going to present 3 scenarios to the two of you, and let's help sort of our community spread the message on the types of tests. Okay, so the first scenario is the pre-diabetic person who's healthy, putting on weight, not eating too well, sedentary lifestyle, poor diet. Okay, and they sort of hitting their mid-30s or so, and starting to be aware of the fact they need to go for annual physicals. And this is not something that the primary care physician is going to talk to them about. So how do we empower this type of person to ask for something when they go to the primary care physician? The second patient scenario is someone with established comorbidities. This is a diabetic patient, hypertensive, metabolic syndrome, high cholesterol, overweight, etc. So they are on treatment for these other conditions. And we know that the comorbidities increase the risk of getting NASH or NAFLD. And then the third patient is a NASH patient or a NAFLD patient who has been diagnosed, but now wants to have more accurate monitoring. So in these 3 scenarios, what are the types of tests we would talk about for these patients? So let's start with the first one.
May I answer first, Wayne? First of all, I need to, I feel like I need to reinforce what Wayne said. It's very important. I think one of the roles of non-invasive tests, it's not only to diagnose a severe condition as cirrhosis, but also to reassure patients, because we have to understand that NAFLD, it's a condition that is existing fatty liver, simple fatty liver, with or without fibrosis. It's existing in 1 in 4 or 1 in 5 patients from the general population, depending on the ethnicity. And so it's a very common condition. So most of the patients will have incipient stages, as the patient, as you mentioned in the first scenario, a younger patient just with conditions predisposing risk, metabolic risk, predisposing to fibrosis or to NAFLD. But these patients should be reassured by the non-invasive testing, and in any case should be addressed for liver biopsy unless there is a high suspicion of advanced disease. But again, even patients that get a result on Fib4 or on any non-invasive testing of severe condition, a more severe condition like fibrosis, because fibrosis is the main predictor of the outcome in a patient. Having simple steatosis, a patient should be reassured, of course, not totally reassured, because having simple steatosis in NAFLD, it's increasing the risk, the cardiovascular risk, like with 70% compared to controls without steatosis. But also these patients should be patients that are at risk for having severe fibrosis should be reassured, because it is a condition that could be controlled. Of course, the follow-up is not the same as in a patient with a moderate or minimum fibrosis, but there are solutions, including lifestyle change, but also therapy trials, therapeutical trials, actually, and soon maybe treatments available. And also these patients should be reassured, because all these conditions could regress. They are not, all this could regress. Steatosis and inflammation are regressing very rapidly, as Wayne presented in his liver fast result. So these conditions could regress once the risk factor is stopped. Fibrosis is regressing slowly at advanced stages. Patients with less advanced stages are not regressing so slowly, could regress rapidly, but even cirrhosis is regressing, and there are studies, for example, with bariatric surgery, showing that these patients that are losing high amounts of weight could regress cirrhosis. So this is a model that exists now in NASH patients. So for the first scenario, I may say, of course, the first thing is to the patient to be aware of the risk of having a liver disease and a cardiovascular, satellite cardiovascular disease, because the liver disease is an expression of the metabolic syndrome in the liver. So when a patient knows that it's part of, has one or more risk factors that are part of the metabolic syndrome, like arterial hypertension, overweight, high cholesterol and the bad one, or low cholesterol, the good one, high triglycerides, or abnormal fasting glucose. This should be a warn for this person that maybe there is a risk. And I think education for the patients, and that will try to search a way to find out how they could be diagnosed, should start with this, identifying these risk factors that are well known. And if they are part of this kind of risk, they should screen their liver. So use a screening method. For the screening method, they should choose a method that is not releasing a high rate of false positive results. Because when we screen, we don't need a method that is maybe good for cirrhosis, but is releasing a high risk of a high amount of false positive results. For screening methods, we need markers that are very good for early stages. And of course, Fib4 is a good one, and liver fast is another one. And I would not advise for this first scenario a screening with FibroScan, because FibroScan has a lot of variability depending on the BMI, on the operator, and has a lot of false positive results. And the screening studies that are published, some of them in Europe, demonstrated that they are releasing something like 3 times more false positive than other non-invasive tests. So I think first step will be a screening with a method that is reliable for early stages in this first scenario.
Okay, excellent. So, and this is where we sort of live in community to keep everyone in check and say, you know, if there's someone that you know that fits that type of profile, encourage them to get that Fib4 at their next physical checkup or primary care appointment. Wayne, do you want to tackle the second scenario where there's established comorbidities?
Well, I would probably have been better on the first one, but sure. But let me comment on that first one. You know, one of the things that we need really, really bad is not necessarily the medical interventions, it's the education, early education in schools, and people to understand these things so that they don't have to learn about it when they are visiting their doctor, because so much of this is really just do what your grandma said, you know, eat your vegetables and go out and run. But when someone, you know, is dealing with an intermediate or, you know, an early stage disease, the real questions that you want to know is, you know, what is my current level of damage and how fast is it progressing, and is my response, are the things that I'm doing to deal with it being effective. And you know, we can't control anything that we don't measure. And one of the real problems that we have in our medical system today is that, you know, we don't provide for monitoring. We don't provide really for that that kind of periodic look at these issues. What we have today is that your primary care doc will maybe look at your ALT, AST, and, you know, they put great faith in ALT, and that's a liver enzyme, and it absolutely does suggest when you have ongoing active liver injury and insult. But, you know, that's not what you want to know, really. I mean, that by the time your ALT gets up to where primary care docs today will respond, you're actually in the process of some kind of consequential event in your liver. And as someone who is in the decade or two long process of having asymptomatic but slowly increasing damage, you might be like I was, and I never had an out-of-bound ALT. So my primary care doc would never, ever have reported me to hepatology. So, you know, we need to change the testing that takes place. And I think that's the role that these various non-invasive blood markers will play in the future, because they can do that monitoring of people along the way, which I think is just vitally necessary.
And so we do have the FIB4, and it's not just looking at the ALT, but it's looking at those 4 parameters, and it gives us a good screener to say you might be at risk. And so the person in scenario 1 should take up the FIB4. In the person in scenario 2, we do have a choice now between the Fibro scan and the liver fast, for example, as a non-invasive test that gets in more detail. And so those are the 2 scenarios that we have or 2 options for scenario 2.
There are actually more. You know, there's a Fibro Sure, there's Fibro Test. There's a variety of tests that are coming along, and there are various tests that are coming through the research labs that are focused on particular more specific things. There's NIS4, for example, which is being sponsored by GenFit. There's ProC3, which is a test of collagen activity. There's a whole range of blood markers that are being studied and developed, and there are various stages of maturity. So we're on the brink of having a variety of tools that people can work with. So we're out on the front end of this. The liver fast and the fiber test are a couple of the early adopters in the field, the kind of the leaders of this next wave of diagnostic tooling that we're going to be able to use.
So this is a question that comes up very often with our patient community, and certainly it's come up in this series of registrations we had for this webinar, and it's, what do I ask my doctor for? And it's directed at the primary care physician, and so I think we sort of in the ballpark of saying, or consensus saying, the Fib4 is our entry level based on that first type of scenario. But in this next battery of tests that are more specific, what does the patient ask for? You mentioned quite a few tests, but what does the patient ask for if it's not going to be initiated from the provider perspective or the physician perspective? Do they ask for a test for fibrosis in the liver? Do they ask for a test for fat assessment of the liver? And it's almost like we have to develop a catchphrase or mantra for these high-risk patients that they go and this is what they ask for.
What you're really talking about, your responsibility as a patient, by the time you get past your primary care doc and you're being evaluated for some potentially serious situation, it ought to be your doctor that says, this is the right pathway. And so, part of what we're trying to encourage is for the medical profession itself to become more proactive with regard to liver diagnosis. I mean, what happens today is that the primary care doc refers you to a gastro doc, and so many of them have very little training in liver disease. So, I guess I'm wandering off into one of my pet peeves here, but we don't do a good job of moving people through the medical community once they have been identified as needing more specific things. So it's really, I'm not sure that this is really a question for Mona, because you have to know more about the patient and their history and things like that to be able to really say, how should I test for this next level of disease, I think.
I think in patients with established comorbidities like type 2 diabetes and severe obesity, like morbid obesity, these patients should be extremely aware. They should ask for a liver-specific test for fibrosis for sure. This is a minimum liver fibrosis test. But it depends why they need that test. If they need to be monitored for their liver disease, because not all of them will have severe conditions, they need also a test for steatosis, a test for inflammation, because if they will have lifestyle changes or drugs or exercise, or diet, they will be able to monitor these changes and the regression, which is visible and significant with every 3% of the body weight that is lost for steatosis, and which is significant also with 10% of body weight loss for fibrosis. But I think the main message here is what is not, what they don't have to ask for. And I think in patients with established comorbidities like type 2 diabetes that have a very high prevalence of NAFLD, 1 in 2 has NAFLD and 1 in 3 has NASH, which is the most severe condition of NAFLD because there is some fibrosis and there could be also inflammation. But in these patients, they should not ask for tests based on liver enzymes. And even FIB4 works less in diabetics. And the patients have to know that 1 in 3 diabetics has normal liver enzymes, ALT and AST, despite having advanced fibrosis, liver fibrosis. So I think what they should not ask is this kind of test, very generic, that is no more intended for them. They have a large panel of non-invasive technologies, of course, like complete panels like LiverFast or MR elastography, or of course FibroScan. They could have this if they don't have limitations related to criteria of reliability for FibroScan. So I think there is a wide range, and in these patients with established comorbidities, I will recommend not a sequential diagnosing for them, but a combining diagnosing, because this is already established. This was more studied in chronic viral hepatitis when these methods were first developed, that when you have a combining approach for non-invasive diagnosing between, for example, a wet biomarker, a blood-based biomarker, and an image-based biomarker, like elastography, for example, you will have significantly increasing the accuracy of your diagnosis. So I think combining is a better approach than sequencing, because when you are sequencing, if you are using the cheapest test first, that is generally free, a free test, you cannot avoid the false negative results. And this is why the approach of combining simultaneously to test, it's always a better approach. And if it is possible, combining those that could complement each other and have a more accurate diagnosis. And we know very well that the non-invasive tests have between themselves about 20% of discordance, like blood biomarkers with transient elastography, FibroScan, about 20% of what is called results that are different, significantly different. This does not mean one stage of fibrosis, it means for 2 stages. But also each blood biomarker has about 20% with liver biopsy. So I think this approach of combining is decreasing this 20% of discordance between tests. So it's providing you some certitude when you have results that are similar for both techniques that you used. And for the third category of patients that has...
I want to link the last question to the third scenario for you to answer, but I just want to sort of sum up on the second scenario with established comorbidities. The thing that patients can ask for is 2 types of liver fibrosis tests, or the combination, right?
The combination imaging with blood biomarkers demonstrated a high diagnostic value.
Yeah, so 2 different types of tests. And for the third scenario, and I think this question that just came in on the chat box links to it, is the FibroScan still recommended for staging of cirrhosis, or is there a move towards the liver-fast testing? If the FibroScan is still recommended, what is the recommended time for follow-up scans to reevaluate the stiffness of the liver based on clinical evaluation or time base?
FibroScan, one of the main indication of FibroScan is to detect cirrhosis. But some other tests like liver fast fibrosis, the fibrosis score from liver fast, it's diagnosing cirrhosis with the same accuracy, with the same performance in the studies that are independent from our company, with the same accuracy as FibroScan, but with what is called a better applicability, a better reliability, because we don't have failures. It's a blood test, and we don't have the same limitations as those related to the technical criteria that are for FibroScan. Because we know people that already get a FibroScan know that about 15 to almost 20% of the results could have non-reliable results or failures, 3% of failures and 15 to 18% non-reliable. So I think this is one of the first thing. And related to the frequency of re-diagnosing, it depends on the therapeutical approach. It depends on the changes. It depends on the risk. If the risk is changing, is decreasing, or it's increasing, of course, there is a need of monitoring these patients. In any case, there is a need to monitor not only, of course, the main factor is fibrosis regression or progression, because even cirrhosis could progress. Cirrhosis, it's a very, it's one word, but it's a very, how to say, very large panel of spectrum for the disease, because coming from early cirrhosis where the patient has no signs, and where a specific liver test, it's very useful to detect it because there is absolutely no sign, to late cirrhosis with complications and which is more difficult to regress. So I think all these patients need a follow-up. It depends on the stage of fibrosis. Generally, cirrhotics are followed up every 6 months, not only with non-invasive tests, but with other types of examinations like ultrasound, liver ultrasound.
Mm-hmm. Wayne?
Well, again, it's part of the fragmentation issue, because I don't believe that FibroScan is officially approved as a diagnostic tool for cirrhosis. I mean, a lot of doctors use it that way, but you know, there's not a uniform standard of acceptance of the tool, just as there's not an acceptance of the non-invasive markers. And it depends upon where you are in the medical community as to what they favor. When you get to the hepatologists, they're going to really like to do MRE, for example, which is a big MRI type device, or they're going to want to do the biopsy. We have a huge difference in practice as to what people are really using to make a diagnosis. So the medical profession itself has a lot of different channels as to the way that it comes to the diagnosis of cirrhosis. So, you know, that's part of why we struggle with how to get through this as a patient, because, you know, it depends. If you switch doctors, you're liable to switch into a whole different strategy for understanding your situation.
Yeah, and I may add just a thing about cirrhosis. Early cirrhosis have a patient could have normal profile, biological profile, and early cirrhosis that could be detected only with specific tests that don't release a high rate of false negative results. Because comparing to screening the general population, where we need to avoid methods that are releasing a high rate of false positive, here we have to avoid methods with high risk of false negative results. And I think here non-invasive blood tests are well positioned compared to imaging because they could detect very early this cirrhotic liver even before any imaging change have been.
Yeah. So there's one more question I wanted to ask, and becoming close to time, and knowing is so important. Knowing is so important, and that's why we have these tests. But there's also a psychosocial impact of getting this test. And Wayne, I'm thinking about the Sunland study where the Fatty Liver Foundation went out and did fibro scans in the community. And I want you to expand on the teachable moment that you witnessed with the FibroScan machine and people getting an indication that they had something going on in their liver. And what do you think the implications are now that we can get the tests done quicker and faster and as part of their routine? And where will this knowing en masse take us as a society, as communities, on behavior change and lifestyle modification? Big question, but that's for you.
Yeah. You want me to give you a 2-minute answer on that? The biggest thing that we saw, and we were using a FibroScan, which gives a very impressive printed output of what the test shows. And it's one that catches people's attention, and it's one that they can focus on and they get emotionally attached to it. And at that point, they're open to what we call the teachable moment. And we found very good success at that point in time of having people actively want to learn and to get information and to we felt take away from the experience things of value that they could apply in their lives. And it's one of the things that I like so much about the liver fast is that it gives me that same kind of striking visual image that people can capture in their mind intuitively, and they can relate to that as to what it means to them. So I think that kind of presentation to patients is so important, because when you just give people this number that says, well, your ALT is 2x normal, and that's not good. Now, it doesn't mean anything. It's not teachable. And that's the kind of thing that we've always gotten from our doctors. Well, you got a high LLC and we want to bring that down. Okay. So it is a lot of presentation value in these kinds of tests, and the immediacy of things is really really good. And that's one of the great values the FibroScan had. Any of the blood markers take some time to turn around, so you don't have that instantaneous process. But if you're following a good program, as you give that information to the patient, you still have that opportunity to teach them, and I think that's really quite important. Societally, we have to learn about liver disease, and that's I think the very best way that we can do that going forward.
Excellent. I mean, it's going to be a game changer, and like you said, we have to enhance that patient experience and pay attention to that, so it leads to that behavior change. Mona, I'm going to open up to you for a last comment before we wrap up as well.
Yeah, thank you so much, Neeraj, and thank you for the excellent point, Wayne. It's very important that we need something quick, but I think we need to be very optimistic with the patients and to explain them it's very good to search for severe disease. It's a very good approach with any method they have that it's proximity method. If blood test is easier for them, then do the blood test immediately. If a fibroscan is closer, it's easier to do a fibroscan. But also we need to have a positive, I think, approach, and to reassure them, because non-alcoholic fatty liver disease is a very slowly progressing disease. And so once you have this diagnosis, if you are not in the category with severe lesions that needs the referral to a hepatologist, you have time to make all these lifestyle changes. And I think this is a very important message, that you have time to check your liver, to check your heart, and to change something in your behavior in order to improve it.
Well, thank you so much, Mona. And I want to thank everyone for participating, and a special thank to our panelists, and also for everyone who participated, for the questions, the excellent questions you submitted at the time of registration, as well as in the chat box. And with that, Wayne, I'll let you have the last word to close off this webinar.
Okay, Gabriella, could you put up that link to the liver fast on our site? I wanted to thank everybody for attending. If you want more information, there's lots of information on our site about all of these subjects. We do provide links to Fib4 and to liver fast, and we have various studies going on and programs that are important to us. And you know, if you ever feel like donating, why, this would be a nice place to do it. And we really thank you for attending, and hope to see you next time at our next webinar.